Hello, everyone, and welcome to the Parkinson's Foundation's Wellness Wednesdays webinar. Thank you for joining us. We will begin soon. Please know that we are recording today's presentation and you will receive a follow-up email from us with a link to the recording and additional resources in about 1 week. We will begin shortly. Thanks for being here. Inspired by the conversation today, please grab your coffee or something hydrating, maybe a warm cup of tea to enjoy during this conversation. We'll be focusing on the subject of anxiety, depression, and apathy, so get your questions ready. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day, for supporting the mission of the Parkinson's Foundation. Before we get into it, I want to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, care partner specific programs, expert briefings, and our Spanish language series, AP Salud en Casa. Be sure to visit our website to see what's coming up and explore archive videos, or visit YouTube. You can learn more about these programs and register at parkinson.org/PDHealth. Additionally, based on who is here today, I'd like to share a few specific resources for those of you who are recently diagnosed and for those who are supporting someone living with Parkinson's. The Parkinson's Foundation offers guidance, emotional support, and resources to help you and your loved ones navigate the diagnosis. For some, a Parkinson's disease diagnosis comes as a relief, an explanation for previously unexplained symptoms. Others may be stunned, struggling with what the future may look like. And as you begin processing your emotions, which can be wide-ranging, it's important to know that you're not alone. Get connected to essential resources by visiting our newly diagnosed webpage. My colleague will share a link in the chat with you all. And for those of you who are supporting someone with Parkinson's, it's important to know the foundation has a space for you too. Whether you're new to caregiving or have years of experience, this dedicated webpage meets you where you are with practical tools, educational content, and emotional support. You'll find printable guides, videos, and tips to navigate the evolving role of caregiving. It also connects you to programs like the Care Partner Summit, our PD Health at Home mindfulness and education sessions, and relevant episodes from our podcast. For those planning ahead, we offer trusted tools like the Hospital Safety Kit, advanced care planning guidance, and legal considerations. Please bookmark or share this page with others. It's a comprehensive starting point and a trusted place to return to as needs change. Here's a snapshot of the conversations to come in the year. These subjects were chosen based on your continuous feedback and expression of your needs. Be sure to stay connected with our virtual education programs by visiting parkinson.org/PDHealth. Today, we return to our Coffee and Conversation series with the Foundation's Chief Medical Officer, Dr. Sneha Mantri. Today's session, we will focus on answering your questions, addressing the symptoms and experience of anxiety, depression, and apathy in Parkinson's. From tremors to stiffness, we know that living with Parkinson's involves more than managing those movement symptoms. Many people also experience emotional and motivational changes that can be just as challenging. In this open conversation, Dr. Sneha Mantri and Dr. Daniel Weintraub will have a thoughtful dialogue about 3 common but often misunderstood experiences: anxiety, apathy, and depression in Parkinson's. And as we move into this conversation, please grab your coffee, tea, or again, a hydrating beverage. I know lots of our experts will invite you to drink more water, so maybe grab a glass of water and prepare those questions about anxiety, apathy, and depression. And as we open our coffee and conversation today, focusing on anxiety, depression, and apathy, I'd like to introduce the Parkinson's Foundation's Chief Medical Officer and Associate Professor of Neurology at Duke University, Dr. Sneha Mantri. Joining Dr. Mantri is Dr. Daniel Weintraub, a professor of psychiatry at the University of Pennsylvania School of Medicine and psychiatrist at the Parkinson's Disease Center at the Philadelphia Veterans Affairs Medical Center. Dr. Mantri, I'll pass it over to you today to open our conversation on anxiety, depression, and apathy.
Thank you, Krista, and thank you to everybody who's joining us. I think the response that we've gotten from the Parkinson's community just speaks to how important this topic is, and how much it can be overlooked in routine clinical care because it gets sort of put to the side when people focus only on the motor symptoms like tremor and stiffness and slowness. But we know that these mood changes are incredibly common for people with Parkinson's disease, sometimes even predating the onset of the physical symptoms of PD. And they can persist throughout the course of the disease and really be a big driver of quality of life. So I hope that in our conversation, Dr. Weintraub and I can answer your questions and provide some sources of support and guidance around managing these symptoms. I do think it's important before we get to the questions themselves to just do some brief sort of laying the foundation or of what these conditions are, because they can be sometimes confused for each other. As Krista mentioned, the three key areas that we're going to be focusing on today are apathy, depression, and anxiety, all of which can happen in Parkinson's. Sometimes people may have just one, sometimes people may have multiple. Depression in Parkinson's is incredibly common. It is characterized by often a feeling of sadness, but also a feeling of not wanting to do things that you typically would have liked doing. And there are other criteria as well, but those are sort of the two key things that we clinically can look for when we're trying to evaluate somebody for potential depression in Parkinson's. Anxiety is also a very common experience in Parkinson's and in people who don't have Parkinson's. But anxiety is sort of driven by this worry or concern about the future, or about future events, whether or not that may be, directly related to your current state, or kind of looking ahead to the future. And lastly, apathy, which I think is probably the most misunderstood of the three. Apathy is something that is, not entirely unique to Parkinson's. It can certainly happen in other conditions as well. But it's not nearly as common in the general population as depression or anxiety might be. And apathy in Parkinson's is usually felt as this sort of lack of motivation or lack of drive. One of my patients described it to me as they have no get up and go anymore, and they just don't feel like doing things that they would ordinarily want to do or like to do. So there is a lot of overlap between apathy and depression, between apathy and anxiety, but it is a distinct phenomenon in Parkinson's, and it has some, distinct treatments. So hopefully those definitions sort of help set the stage for what we're going to be talking about in today's conversation. As you saw from the list that Krista had, we've got upcoming conversations in later on this year on a variety of topics. So if your questions aren't answered by this one, we hope you will join us for one of our future talks as well.
Thank you, Dr. Mantri, for giving us sort of the synopsis and a brief understanding of what apathy, anxiety, and depression is in Parkinson's disease. And I'd like to invite Dr. Weintraub to join us for this conversation around these three commonly misunderstood symptoms in Parkinson's disease. Dr. Weintraub, anything to add to provide sort of a baseline with our community before we jump into answering questions?
First of all, thank you for the invitation and welcome to everyone. And I think Dr. Mantri, but I'll call her Sneha because I've known her well now for a long time. Sneha, I think introduced the topic very well, so I don't want to take more time up with introduction at this point.
Would love to start a little elementary as we explore anxiety and depth in Parkinson's disease. How is Parkinson's disease related anxiety different from a person who does not have Parkinson's disease? And I'll say regular anxiety. How does it different with someone with Parkinson's?
So I guess I'll go first on all of these, and Sneha can jump in at any point, of course. So that's always been like somewhat of a dilemma or conundrum for many psychiatric symptoms. How do the symptom presentation in Parkinson's compare with what you would see in the general population? And that could include psychosis, depression as well. In terms of anxiety, I'd say the three main presentations of anxiety are generalized anxiety, which are a day in, day out sense of excessive worrying or physical symptoms of anxiety, but present most of the time and somewhat atypical and out of proportion for what might be expected by most people, or atypical for the person based on what they experienced prior to Parkinson's disease. Then there's avoidant behaviors, which can take several forms. So that would be perhaps a fear of going into public, a fear of being seen in public. Sometimes it's concern over the presentation of the Parkinson's symptoms, such as tremor in public and how people might perceive that. But there's various fears that may occur. And then finally, there's discrete anxiety or panic attacks that can occur. Those often come up in the context of what we call non-motor fluctuations or off periods, where people can become so anxious as their Parkinson's medications are wearing off that they experience these anxiety attacks.
I appreciate you differentiating the three different types, Dr. Weintraub. And I'm curious, we talked a little bit about having anxiety for those off periods of Parkinson's disease. What are some ways that we can reduce this anxiety that's related to the movement symptoms?
So usually the first attempt, and again, I don't want to cut Dr. Mantri off if she's going to say anything, but I'll go first and then I'll wait and see what she wants to add. Usually, as a psychiatrist, my initial handling of that situation, particularly, is to defer to typically the movement disorders neurologist in the setting where I work to see if there's any adjustments that could be made to the Parkinson's medications to kind of smooth out these off periods so that they're less likely to occur with the hope that then the anxiety attacks will diminish or go away. After that has been attempted, and there's many strategies available for the movement disorders neurologist to do that, then sometimes I'll introduce psychiatric medications if necessary, and that could be either an antidepressant first line or perhaps a pure anti-anxiety agent, which is a benzodiazepine as a second line agent.
Yeah, I would absolutely agree with that. And this is one of the things that I think neurologists and psychiatrists often work very closely together on. Often when a patient will come to me and say, I'm having anxiety or anxiety attacks, the first question I try to ask is what could be triggering it? And if we do identify that it's related to the timing of their medicine, like their medicine is wearing off, or sometimes what I hear is right after I take my pills, within a few minutes, I start feeling anxious. And actually, that's sometimes it's related to side effects of the med itself, but often it can be related to that previous dose that is sort of still worn off or wearing off, and this next dose hasn't quite kicked in yet. So it's really important to try and suss out, to what extent this may be related to timing of dose, or if you take your medication like your levodopa with a large meal or a lot of protein, it might not get absorbed as well, and then you might be feeling anxious because you didn't get quite enough dopamine on board, if you will, and so you're still sort of off. So that's often my first step, is try to figure out if it's related to particular triggers and could those triggers be medication related, and then try and, as Dr. Weintraub said, figure out ways to smooth out their dosing curve, if at all possible, by adjusting the type of medicine they're taking or the formulation or the amount per dose to try to get things as steady as possible. And then if that's not effective or it's not effective enough, then I turn to my psychiatry friends to talk about, what other strategies can we use? Do we need to add another medicine to help with anxiety symptoms, either as needed medicine or a everyday medicine to reduce the anxiety risk?
Mhm. I'm hearing two things. I'm from our audience. There's one understanding, what does it mean to have a trigger that leads to an anxious period, an anxious experience? And we're talking a lot about medication treatment for anxiety. So I would love to explore, based on a question we just got from one of our audience, how can I manage anxiety without medication? So would love to identify what we mean by a trigger that could invoke anxious feelings, and how we can potentially cope with anxiety without using medication.
Yeah, say in general, beyond even anxiety, more broadly, when you're approaching a psychiatric symptoms, there's kinds of two major treatment options available. One are pharmacologic, which is what someone like me will typically default to as a psychiatrist, but then there's non-pharmacologic treatments as well. And in this case, for anxiety, there's a whole literature of what we call kind of cognitive behavioral techniques that are used both in depression and anxiety. And those are techniques typically learned through working with a psychotherapist or a counselor, where you're identifying the thinking or the thoughts or the triggers, as you were mentioning, that might be associated with a specific anxiety episode, and finding ways to work with those thoughts to try to alter your thinking, your automatic thinking that might be associated with anxiety, or focusing on the behaviors themselves. So ways to modify one's behaviors. I'm not going into any specific details, but there's a whole manual that can be followed, where people will learn techniques often over multiple weeks, like 10 to 12 sessions of weekly therapy, to learn the cognitive and behavioral techniques that might allow them to better forestall the onset of anxiety or minimize the symptoms when they occur. The only thing I'll say, though, is that may work better for some kinds of anxiety than others, like the kind of anxiety we were just talking about, where it seems clearly related to the off periods of medications, like the levodopa wearing off. That seems a little harder for me to imagine that cognitive behavioral techniques are going to kind of solve that problem specifically.
I imagine, though, Dan, and this is a question for you, really, for me, is that like, would those types of techniques potentially work better on like situational type triggers, like being in particular spaces or, anticipating things that are coming, down the pike? Um,
Yes, very much. I think if you have a specific fear, or it might even rise to the level of a phobia, or a fear of being alone, or a fear of being in public, or there's certain situations. People often feel this very anxious coming to the doctor's office, as I'm sure you've heard before, Dr. Mantri, that anything that's kind of out of the regular routine can be enough of a trigger for a Parkinson's patient to make them anxious. I think those are the kinds of anxiety-provoking situations or stimuli that can be managed through cognitive behavioral techniques.
Mhm.
yeah.
So if we were using cognitive behavioral techniques, CBT, in a situation that's not related to a loss of dopamine. So we're not delayed in taking our medication, but we're experiencing anxiety starting to escalate. How might we be able to manage that? If we could give an example of using this behavioral technique, how could we learn to cope with anxiety when we feel the onset of it?
Um, well, from some of the pure kind of physiological behavior techniques include things such as mindfulness techniques, relaxation techniques, deep breathing techniques, particularly if it's rising to the level of an anxiety attack, which might help lessen the likelihood of that progressing. Um, a lot of the cognitive techniques relate to kind of like correcting distortions or specifically looking at fears that might happen. So again, it's hard to go into too many specifics without having an individual case example to address. But for instance, if it's a fear of have a tremor being exacerbated in public, as it often is under stress, Parkinson's tremor can worsen. But like kind of thinking through the process of like, what's the worst that's going to happen? Are people really going to think less of you if they see you with a tremor or think there's something wrong with you? And so there's a whole list of things that can be gone through that typically I think can be quite helpful for people.
One technique that I have heard about, and have recommended to people, I don't know if it's officially cognitive behavioral therapy, but this idea that, to talk to yourself in a with kindness and compassion. What would you tell a friend that is experiencing this fear or worry? And that can be a really useful way of sort of reframing what's happening, to your point, Dr. Weintraub. And the other technique, which is I think more along the lines of the deep breathing exercises, things like heard it called box breathing or 4x4 breathing, where you breathe in for 4 seconds, hold for 4 seconds, breathe out for 4 seconds, and then hold for 4 seconds. So if you imagine almost like a box that your sort of breathing makes. And what that does physiologically is activate your parasympathetic nervous system, your vagal nerve, slows down your heart rate, and sort of works to combat or prevent that sort of rising tension or rising feeling that many people with anxiety or anxiety attacks can get.
I like that. And to the extreme for anxiety attacks, people still sometimes will use a paper bag to breathe in and out of because you're rebreathing carbon dioxide, which tends to help mitigate the hyperventilation that can lead to the panic attacks. So yeah, I think there's any number of techniques that can be used that can be quite effective. And I like your ideas.
So what I'm hearing, anxiety in Parkinson's can be related to medication, in between medications, some anxiety about medication, some anxiety induced by medication, and also anxiety about living with Parkinson's. And some of these modalities that we've explored are pharmacological, using your words, Dr. Weintraub, and also habits, thoughts, and using a team, whether it's a psychiatrist or mental health counselor or breathing techniques to learn how to use these habits when that experience of onset anxiety starts to build in our day-to-day life. How does that sound as a roundabout way? Okay.
Yeah, I like the summary, and I'll just tell people again for almost every psychiatric symptom, I think of three possible contributing components. So I would recommend other people might at least try that. One is there a disease effect? So for instance, anxiety, as Dr. Mantri already mentioned, can be a prodromal or pre-motor symptom. So that speaks to kind of the biology of anxiety in Parkinson's because people haven't even been diagnosed with the illness yet, but are still at an increased risk of anxiety. And then there's the psychological aspects. So what might be triggers, factors in the environment or internally that might be contributing to anxiety. We're all vulnerable to that one way or another. And then finally, what are the possible medication or disease treatment effects? So what if impact could the Parkinson's medications be having for better and for worse? And in this case, maybe the one link with anxiety would be these non-motor fluctuations we're talking about, that with chronic exposure to levodopa, you may be at increased risk of symptoms such as anxiety attacks.
Thank you, Dr. Weintraub. Dr. Mantri, if we hear ourselves in these questions that we're having answered by you and Dr. Weintraub, what would be the first step that we might take if we recognize this is me or I hear myself in this experience? Where might I start?
Yeah, I think there's several different places to start, and none of them are mutually exclusive. I think if your anxiety or your mood symptoms are rising to the level where they're causing functional impairment, right? You're afraid to go out because you're worried about your tremor getting worse, or you're having panic attacks or anxiety attacks that are preventing you from doing what you need to do or want to do in a given day. I think the first step is absolutely to reach out to your care team, whether that's your movement neurologist, your mental health specialist, a counselor, and sort of get your people on board and let them know that this is happening to you. Because, as Dr. Weintraub and I have both alluded to, there are a lot of things medication wise that we can do to help people navigate these difficult situations. I think there's also, particularly if your symptoms are not maybe hitting that level of distress of needing medication, even if they are. I think the Parkinson's Foundation is a fantastic resource, both in terms of educational materials to help people understand what's happening with anxiety and depression and all of these mood symptoms in Parkinson's. For instance, webinars like these and our regular Mindfulness Monday series and Wellness Wednesday series can be very helpful at focusing on some of those non-medication techniques to help navigate things. And also the Parkinson's Foundation has a helpline that's really, really helpful for helping people get access to or reach out to either community resources in their area or online resources that can help navigate these difficult symptoms. So certainly I think reaching out to your care team, going to parkinson.org website and calling our helpline are three things that I would recommend to anybody with Parkinson's who, is listening to this webinar and thinking, oh, wait a minute, this might be me. I might need to do something about this.
Thank you for those call to actions, Dr. Mantri, and giving us a direction if we do find ourselves in these and identifying with this experience, what we can do about it. There's lots we could continue exploring around anxiety, and I want to recognize the time that we have together, and we have two other important symptoms to address. Let's move into apathy, the loss of motivation. And Dr. Mantri, if you could just real quickly remind us, what is apathy in Parkinson's?
Yeah, absolutely. So, as you just said, Krista, it's really the lack of motivation or loss of motivation. Many people find that they don't have the drive or the desire to do things that they used to really like to do in Parkinson's. And it's not caused by, or it's not that they're not doing something because of a motor impairment. It's not because they physically can't do it. It's just they don't feel like doing it anymore, is probably the best way I can describe it.
And why is this present in Parkinson's? Why is this a symptom so prevalent and significant in how we experience our Parkinson's disease?
Yeah, it's very much, I think, related to the dopamine transmission in the brain. We often talk about dopamine as the chemical that helps us with movement, right? The stiffness and slowness and so on that can come when you don't have enough dopamine on board. But dopamine is also really fundamentally involved in the reward pathways in the brain through a slightly different brain network. But if you don't have dopamine on board, or you don't have enough dopamine, or it's not being transmitted or processed in the right way, you just lose that sort of reward happiness cycle that encourages you to do the things that you like to do. And so you don't get that, to the extreme level, a rush of endorphins. You don't get the reward out of doing the thing. And so you gradually might stop doing the thing. And it's often a very gradual change. Sometimes it's not even the person with Parkinson's who notices it. It might be their care partner or a friend or somebody else who points out to them, hey, you're not, you used to really like, I don't know, going for, Sunday brunch, and you just don't seem to want to do that anymore. And again, it's not because they physically can't or they're worried about it. It's just they don't feel like doing it is how people will often describe it.
Mm. I'm looking at all the questions that are coming in about apathy, and lots of them are, why don't I care anymore? Is this apathy? Is this depression? Why does my husband not want to do anything? How do I push through when apathy hits? So, thinking about this arc of how apathy impacts quality of life, how do we, as people living with Parkinson's, sort of motivate ourselves or push through? I don't like using the word push through, but how do we live recognizing that this is a symptom of Parkinson's? It is not me. And how can I continue living a life that feels fulfilling?
Yeah, I mean, I think framing it in the way that you just did actually is a really good reframe. This is not me, this is the Parkinson's, and this might be related to, again, coming back to like, is it because your meds aren't working well? Are they wearing off? Is there something happening there that we can help adjust or smooth out? There are also medications that are a little bit more targeted for apathy symptoms in Parkinson's. Again, I often pull in my psychiatry colleagues here to sort of help me decide which of the wide variety of medications might be the most effective. And sometimes for some people, it just comes down to sort of making a list of things that I want to do today and getting through as, you know, as far down the list as you can or you want to. I always say that with a little bit of caution because I don't want people to say, oh, I didn't do all the things on my list and therefore I didn't, you know, succeed. It's not about that. It's about sort of organizing your day and organizing your life in a way that helps you get to what you need to do.
Dr. Weintraub, what might you add when we think about experiencing apathy? How could I overcome my apathy or combat this feeling of low motivation to do the things that I know that I enjoy doing, I just don't feel like doing them?
I do think because, as Dr. Mantri already said, kind of limited awareness and lack of motivation or initiative is our core kind of features of apathy, that it may not be realistic to think that the person who's experiencing the apathy is going to pull him or herself out of it um, by him or herself. So I think we often rely on external motivation, which could be most commonly a care partner of one type or another, to help kind of motivate the person, structure activities. Because often when a person starts to engage in an activity, they're able to complete it, they're able to enjoy it, but it's just the initiation part that's the most difficult. Um, Increasingly, with all the technological advances going on in the world, there's um, apps that are being developed to kind of help motivate people. So you can rely maybe on a device to be kind of the stimulation, not just another person. And there's actually research ongoing for this. Um, so those are kind of maybe more the behavioral techniques to get people going. And then, of course, as Dr. Mancher has mentioned, although we don't have much evidence for psychopharmacology anyway, we do try, there are different medication classes that we will at least try if the apathy is significant enough.
Lots of questions from our caregivers chiming in about apathy and the impact their person with Parkinson's and their apathetic sort of demeanor has on them. One of the questions we're getting continuously is feeling like a nagging coach versus
Mhm.
a loving caregiver. So, how can a caregiver encourage their person with Parkinson's without nagging and still maintain whatever relationship they have, whether it's a dad, a wife, a husband, a mom. So not feeling like a nagging coach, but a loving friend, if you will.
Yeah, I think that's a great question. And it's a real challenge, I think, for anyone living with Parkinson's and the people around them who are supporting them, because, you know, that relationship does change sort of by virtue of having Parkinson's. You know, sometimes if you're an adult child caring for your parent who has Parkinson's, sometimes that parent-child dynamic feels like it gets reversed, or, you know, two spouses feel like, you know, not equal partners anymore. There's this kind of shift. I think, you know, trying to, as much as possible, give the person with Parkinson's the agency and the sort of decision-making capacity within reason. You know, I worry sometimes about potential cognitive impairment or other things that might impact people's judgment, particularly at later stages of Parkinson's. But for the care partner to sort of give the person with Parkinson's perhaps a few different options or a range of options to allow them to then choose and feel included and feel like a participant in the decision, it can be really helpful. This is also a space, I think, where counseling can be tremendously helpful, both individual counseling and couples counseling, if appropriate, to help people navigate this, you know, really profound change in the way that your relationship might be.
Yeah, there's another interesting question that's coming through from our audience is when we're speaking to anxiety and apathy, and I'm a caregiver, but my person with Parkinson's doesn't acknowledge these symptoms as part of their Parkinson's, how do I, as a care partner, navigate that? living with someone who's either not willing to see that these are symptoms or simply unaware of these symptoms, and the care partners can see them pretty obviously. How do we navigate that?
I'll jump in here. I think these are, Dr. Manchi already said, these are really difficult issues, and there's no simple or clear answers always. Um, I think for many of these symptoms, and I think like hallucinations falls under this, or delusions, anxiety, apathy, things that are kind of heavily biologically related to the illness. I encourage people to always remember first that the identified patient may not be aware of this. It certainly isn't really anything under their control necessarily. It isn't through the fault of the patient. But likewise, it's really not necessarily the responsibility of the care partner to assume full, responsibility for the solution. You can do your best. And it may mean repeating things, and it may mean working with somebody who doesn't identify the symptom, whether it's apathy or believing that a delusional belief is untrue when you know it to be untrue. These situations are confronted frequently in Parkinson's disease. So I think you just have to kind of feel, confident um, in your approach, that you're just trying to be helpful to the patient, to the situation, to not take things personally to the extent possible, to not feel like you're just bugging someone, but that this is the solution that's needed, and it just means repeating something, maybe multiple times a day. I mean, it's all easier said than done, but the more you can kind of treat this less as like um, a failing on the part of the patient or yourself, or kind of pulling the emotional responses out of it and just treating it as kind of like another medical condition that is a symptom that just needs management. And this is your way to manage the problem to the best of your ability.
I want to reiterate, these are hard conversations, and the fact that we have this number of people showing up to have these conversations is significant. So just want to applaud you all for being present and starting the conversation here. Whether you are living alone with Parkinson's or navigating this with a partner, um, we see you. And Dr. Weintraub, you mentioned not taking responsibility as a caregiver for the person with Parkinson's sort of emotional state. And we got quite a few responses when you mentioned that. There's several people here who are navigating Parkinson's disease on their own. They do not have a care partner. And when we think about apathy, what might you offer to someone who is navigating the apathetic side of Parkinson's disease on their own?
It's a challenging one. I mean, I think it's hard to be alone, whether or not you have Parkinson's. I mean, if you're just alone in life or feel that way, that's a difficult situation, particularly as you're getting older, to navigate all that life is throwing your way. But to navigate Parkinson's by yourself, if you literally don't have a care partner, a spouse, or adult children involved, or friends, if that's the case, it is hard. Um, but I think then, there are people that live alone and happily. I think those people, have to rely on themselves to kind of really have a structured calendar to kind of keep activities going. So they're not just like isolating themselves in their house, hopefully, but keeping up like a regular schedule that involves cognitive stimulation, physical stimulation, social interactions. I think we kind of have a sense of what it means to do these things. But then you're just really relying on yourself to put a calendar together or an activity schedule that you'll be able to stick to.
I'm smiling because it sounds like fun for me to put together a calendar of cognitive, physical, social activities that we get to do with ourselves or in the community in some way. So thank you for that suggestion, Dr. Weintraub. Whether we are navigating it alone or alongside someone, having a calendar that can really invite us into opportunity for connection and to things that we love, can really help us live vibrantly, with apathy. There's so much more again that we could continue discussing about apathy. Dr. Mantri, Dr. Weintraub, anything more to share about apathy before we move into our conversation around depression?
just to say that, this, like with anxiety, this is an area that your care team wants to know about because we want to be able to refer you to resources, whether it's, different medications or counselors or therapists or things in the community. It's helpful to let your care team know if you think you're experiencing apathy. And it's helpful too to go to the Parkinson.org website to call our helpline if you're experiencing something that you're not sure if it sort of rises to the need of reaching out to your care team. You can always talk with someone on our end at the foundation to help you decide what your best next step might be.
The only thing I would add was it had come up in the questions we had seen beforehand that differentiating apathy from depression is important. Sometimes care partners assume if somebody's kind of sitting around and not initiating activity or conversation, that means the person must be depressed, but that's not always the case. And so that's one point. And then two, I liked going back to the beginning of the apathy conversation when Dr. Mantri highlighted the role of dopamine. In a very rough, kind of superficial way, we can kind of think of apathy as kind of like a hypo or dopaminergic state or an under dopaminergic state that's kind of core to Parkinson's, contrasted with what we call impulse control disorders, which are kind of in an excess of dopamine state, where people can develop compulsive behaviors. So if you kind of can see those as kind of sitting at opposite ends of the spectrum. And the reason for mentioning that is because some of the pharmacological treatments for apathy involve reintroducing dopamine in some way.
Appreciate ending that conversation on hope. There's things that we can do, and there's medications that can help, and recognizing that this is part of the disease related to the loss of dopamine or the influx of dopamine, whether that's medication or not. So thank you, Dr. Weintraub, for synthesizing that for us. It was a great segue into differentiating apathy and depression. So, Dr. Mantri, would you help us learn what the difference is between depression and apathy? Let's understand that first before we get deeper into the questions.
Yeah, I think depression, as distinct from apathy, really involves this component of feeling sad or being sad or not able to do what you sort of normally would have done. So, it is very closely related to apathy. And as you said, Krista, people who are experiencing apathy can sometimes be mistaken for experiencing depression or vice versa, because they both involve the dopamine pathways. They both involve very similar sort of mood changes, with the sort of added component, I think, that depression often, not always, but often involves a feeling of sadness or loss or grief that sort of goes alongside that. Many of our depression screening questionnaires, for instance, will ask specifically about those issues, grief or loss or a feeling of sadness, to help us differentiate between depression and a whole host of other mimicking causes like apathy.
Is depression in Parkinson's different from, we'll do regular depression? And maybe Dr. Weintraub, you could give us a scale again as you did with anxiety and differentiate between Parkinson's depression and other forms of depression.
And just to Dr. Mantri's last point, I agree. So when I try to differentiate apathy from depression, the three kind of components I keep in mind are the mood component. She mentioned sadness, feeling down. That would be more specific to depression than apathy. Then there's cognitive symptoms of depression, so feelings of helplessness, hopelessness, thoughts of death or even suicide in the most extreme cases, or guilt. Those are not typically part and parcel of apathy. And then finally, then this is a harder one, but vegetative symptoms of that typically go with depression more than apathy, like decreased appetite, decreased sleep. The issue there is that Parkinson's disease itself is associated with decreased sleep and decreased appetite. So that is not as specific for depression. And in terms of depression being different in Parkinson's than in the general population. It was thought that that might be the case, but it's really not clear that it is. It seems like the main symptoms that occur in depression in the general population are the same symptoms that occur in depression and Parkinson's disease. Again, it's not so easy to diagnose depression and Parkinson's disease because most of the symptoms that are diagnostic for depression, changes in sleep, changes in appetite, changes in attention, um, and decreased motivation is one of the symptoms actually as well. Those are, we've already talked about, are common in Parkinson's disease. So how do you know whether to attribute that to the Parkinson's itself or to a depression syndrome in Parkinson's? That's not so easy. So it isn't really clear that there's a unique depression that occurs in Parkinson's disease that's qualitatively different than the depression that occurs in the general population.
Mm. How how would you diagnose depression in Parkinson's disease? This was a question we just received from one of our audience. When we're living with Parkinson's, what does the diagnosis look like for that? What does the process look like for that?
Say the diagnostic criteria, it gets into a little bit of circular reasoning, but the diagnostic criteria, the rating scales that we use are really the same as we use in the general population. So of course, we're going to get the same answers in the general population. To have something different, we'd have to define depression and Parkinson's disease as different and then develop new criteria or new rating scales. So we're always, for the moment anyway, or forever, up until now, been wedded to the diagnostic criteria for depression in the general population. So it does involve all of the symptoms we just talked about, sad mood, loss of interest or pleasure, changes in appetite and sleep, um, feelings of guilt, feelings that life isn't worth living, problems with attention or concentration, feeling slow, which of course is a core symptom of Parkinson's as well. So these are the symptoms that are diagnostic for depression.
And
We're getting
I was just going to add, I think, Dr. Weintraub's alluded to this, but there's so much overlap between some of those symptoms and the, say, motor features of Parkinson's, right? Like sometimes people with depression may not seem as happy to others. They might not, and that's also one of the features of Parkinson's, that people can have this reduced affect or flat affect. Mood and affect are different things. Affect is how you appear to the outside world. Mood is how you're feeling on the inside. So they're not always the same, but people will often look at someone with Parkinson's and say, oh, that person's not, their face isn't reacting, they're not smiling as much as, I would want them to or expect them to. And so maybe they're depressed. And so I think it's important to go back to those rating scales and those screening tools and really kind of look through those and try to determine to what extent the symptoms and signs that you're seeing are due to depression or due to Parkinson's or some mix of the two.
Say, just to follow up on Dr. Mantri's point, in general, I'm not talking about the psychotherapy approach, but more the medication approach. I tend to be err on the side of considering it might be a depressive syndrome as opposed to something else because I don't want to deny someone treatment and the opportunity to improve in terms of these symptoms without knowing for sure. And that's also due to the fact that the newer antidepressants that we use now are quite safe and well tolerated overall. So there's really very little downside or risk in at least a trial of an antidepressant if there's any thought that this might be a depression syndrome.
It's a great segue to treatment of depression. We've got lots of questions about how to treat depression and specifically around, are there antidepressants that work best for someone living with Parkinson's disease?
I wouldn't say there's like work best. That would be too strong a statement, but it's easiest to point to what's been shown through kind of the gold standard for clinical trials, which are called randomized controlled trials. So there have been numerous studies and positive studies suggesting that what are called serotonin reuptake inhibitors or SSRIs, and then another class similar to that called serotonin norepinephrine reuptake inhibitors, SNRIs. So those are two classes of newer antidepressants. and also even older antidepressant class called tricyclic antidepressants, shown to be beneficial in clinical trials. And then even one of the class of Parkinson's medications, dopamine agonist, has had some positive benefit in clinical trials. So there's actually pretty good evidence now that multiple classes of antidepressants may be efficacious or effective for treating depression and Parkinson's disease and well tolerated overall.
There's a question from David who is asking us to comment on how lack of sleep and adequate rest contributes to depression, anxiety, and apathy. And we did mention when you were sharing at the start of this conversation about around depression, the influence and impact of sleep has on depression. So, Dr. Mantri, could you just revisit this subject line of sleep and its relativity to depression?
Yeah, it's a great question because I think it's sort of what we sometimes think of as a bi-directional relationship in a lot of ways. Depression and other mood changes can impact your sleep, and sleep changes can impact your mood. And so sometimes it kind of turns into a cycle, if you will. Often people who have lack of sleep, either difficulty falling asleep or difficulty staying asleep, will report the next day that all of their Parkinson's symptoms are worse, both the physical and the non-motor symptoms. By the same token, one of the biggest causes, one of the most common causes of that lack of staying asleep in particular, the early morning waking up at, 2 o'clock, 3 o'clock, and then you can't fall back asleep. Um, uh, One of the most common causes of that is depression, and sometimes is unrecognized or under-recognized as a big driver of that kind of early morning waking cycle. It's important, always when you're talking about sleep issues to also rule out or look at, could it be a primary sleep issue like sleep apnea, for instance? Or an issue that's totally unrelated to sleep, like you're getting up at 2 o'clock to go to the bathroom or something. But barring those types of things, when I hear from somebody that they're consistently waking up at 2 or 3 in the morning and they just can't get back to sleep, the first thing I'll think about is like, what is their mood? Are they feeling anxious? Are they feeling depressed? Do we need to do something about that component? Because I think it's often under-recognized as a symptom or an indicator of depression in particular.
Mhm. Dr. Weintraub, anything to add around sleep and its relationship with depression?
Um, I will just not specifically, but I will say sleep disorders are so common in Parkinson's disease. It's unfortunate again. I mean, people as they get older already sleep less compared with when they're younger in general. And then you add Parkinson's disease on top of that, but some surveys, estimate that 80 to 90% of Parkinson's patients have some sort of sleep disturbance, either trouble falling asleep, staying asleep, waking up too early, or having vivid dreaming behaviors that some people may experience. And it becomes very complicated to sort out the situation in terms of its impact on any other symptom that someone's experiencing.
Mhm. Yeah, anxiety, depression, and apathy and Parkinson's is complex. It's complex. It weaves into so many important aspects of our life, sleeping, social connections, doctor's visits, all the things that make us feel like we're leading a fulfilling life is impacted, especially by these symptoms of apathy, anxiety, and depression. And I appreciate you, Dr. Mantri and Dr. Weintraub, leading us through this conversation. And there's a question that I'm seeing in our Q&A here, several people sort of not knowing how to communicate this with others. How can we help others understand what we're going through?
Yeah, that's a really good question because I think one of the hardest things with mood symptoms in particular is that they are often so internal, and it can be hard to sort of express that to other people. Even all of the things that Dr. Weintraub and I have been talking about have been relying on the person's own self-report, and how do you report your symptoms well and advocate for yourself in a doctor's visit when there's so many other things to, get through or to talk about. I think one of the things that I really encourage people to do, and that, I do myself, is keep a journal, because keeping a record of how you're feeling can be a really useful tool to then look back at and see, is there a trend in how I'm feeling over time? Is it changing? I know some people, I tend to sort of journal in a very traditional way. Other people will even use a phone app to just do a quick check-in every day, and then sort of see the trend of their mood or their other symptoms over time to help then solidify the conversation with your care team about, this is changing or this is different. And it can be helpful to have that record in a lot of ways.
Dr. Weintraub, anything to add about how we can help others understand what we're going through?
Maybe just to shift or reframe it a little bit. I will say that so this is what I've focused on for the last 25 years. And so to be kind of, again, hopeful, I think the field has really evolved a lot in terms of thinking of Parkinson's disease at one point as primarily a motor disorder to now recognizing that a lot of these other non-motor symptoms can occur, not in everyone, but a fair number of people. So I think just making it part and parcel of the illness will in the future make it much easier for patients and clinicians and family members to just think of it not just as a disorder of tremor or stiffness or balance, walking, but this that any number of one of these symptoms can occur and it'll make it easier to talk about, I think. And parallel with this are movements underway to, as Dr. Mantri knows, to kind of reconceptualize how we diagnose Parkinson's disease like as early as possible, but also to kind of broaden the number of the types of symptoms that can be included. So cognitive symptoms, psychiatric symptoms, motor symptoms, but kind of putting them on a level playing field. So I think moving forward, more and more Parkinson's disease won't be thought of as just a motor disorder, but kind of more of a complex, as I like to think of it, a neuropsychiatric disorder, really. So then all these symptoms we're talking about today will just become like the new core symptoms that people hopefully will be more comfortable to bring up. Clinicians will be more mindful to ask about. There'll be more treatments available. That's my hope anyway.
As we conclude our coffee and conversation today, I'm curious to round us out and sort of give us more hope, Dr. Weintraub. What can we do? What can we do if we see ourselves in these conversations? Where do we start?
I do think not keeping things to yourself is best to the extent possible to share, whether it's with again, a care partner or with a clinician ultimately. Um, and I do like to remind people to not hold yourself responsible for any symptom that you have. I mean, I think that's kind of part and parcel again of the training we get as psychiatrists that none of this is through any fault of the individual. I think sometimes people are reluctant to bring things up or may feel embarrassed or ashamed, but really these are just either, for the most part, disease related or treatment related complications. So I encourage people to the extent possible to just be open about them and to give yourself the opportunity to maybe get some relief for some of the things you're experiencing.
Thank you, Dr. Weintraub. A reminder that um, you do not have to do this alone, and healing happens in community. So continue. Start now if you haven't shared with someone you're experiencing these symptoms, and call the Parkinson's Foundation helpline if you don't know quite who to talk to yet. Dr. Mantri, anything to add before I close this out?
Yeah, I just want to echo what Dr. Weintraub just said, that these are very, very common symptoms of Parkinson's. And I think historically, we as clinicians have done a really poor job of recognizing them and addressing them, but that is changing, both in terms of treatment options, in terms of, medications, non-medication options. and just the awareness and the openness with which people discuss mental health conditions. And so please reach out to a trusted friend, loved one, care partner, your care team, the helpline. Like there are many, many people who are here who can support you and can help get you the what you need to live well.
Can I share one last thought, or is it too late?
Please, please.
I mean, if people want to think about how ways they can contribute, Dr. Mantri and myself are both in fields that are kind of underpopulated, mine grossly underpopulated. I mean, people like me who see Parkinson's patients as a psychiatrist are, there's a handful, in the country. I'm not exaggerating really, but so to the extent that one ever has the opportunity to advocate for either it's legislation or to encourage people to be supportive of neurology or geriatric psychiatry. These are fields that are typically kind of not as well compensated as other specialties in medicine, or to encourage mental health professionals to go in to work with Parkinson's patients through increasing reimbursements for services. I think that can only help like the care that's available for people. Because it's fine for Dr. Mantri and I to talk about this, but she works at one academic center, I work at another, and we're only available or accessible to so many people.
Thank you for that call to action, Dr. Weintraub, advocating for ourselves and the people that we love, navigating this journey through Parkinson's disease and this thing that we call human experience. If you had a question that we didn't have a chance to get to today, please know that you can call our helpline. Information's here on the screen. They'd be thrilled to speak with you and learning how to support you in the needs that are really prevalent for you today in this now moment. So please don't hesitate to reach out to our helpline. The Parkinson's Foundation is a trusted live support service available to care partners and anyone impacted by Parkinson's. Our helpline is staffed by nurses, social workers, and Parkinson's specialists. It's a place where you can get answers to both medical and non-medical questions. So beyond information, our helpline team also provides emotional support, helping you feel heard, validated, and empowered. It's one of the best tools for connecting you with additional resources like movement disorder specialists, neurologists, and other Parkinson-specific healthcare professionals, local support groups, online support groups if you're in a medical desert area, wellness programs, education programs, and so much more. The services and support are provided for free. They're confidential and bilingual. We offer specialists who speak Spanish as well. So encourage your care partners and those of you who are living with Parkinson's disease to call our helpline. Before you go, please just take a moment to give us some feedback. Your feedback does fuel the topic of conversation that we have here with our Chief Medical Officer, Dr. Sneha Mantri, and other experts, as well as our other Parkinson's Foundation PD Health at Home Wellness Wednesdays webinar. So please just take a few moments to give us your input on that survey. All right, my friends, thank you so much for joining us. It's been an honor to have shared this time with you and hope that you found the information and resources helpful on your journey. Please know that you are not alone. Our community is here to support you every step of the way. Your strength, resilience, and dedication inspires everyone here at the Parkinson's Foundation, and we're grateful for the opportunity to be a part of your journey. Take care and be well.